of Pediatric Hematology, Oncology, Epidemiology, and Blood and Marrow Transplant. Welcome to this very special occasion. Just to give you a little history, Mark is here with us, and this is indeed the 22nd lectureship, and this is really to honor Mark's incredible career and legacy in the field of pediatric oncology. Mark is one of the founding fathers of the Children's Oncology Group, originally known as the Children's Cancer Group, and really because of his leadership in that area and in international works, really the field of pediatric oncology progressed to where we know it today. And Mark led the initial studies in leukemia, Ewing sarcoma, and histiocytosis, and was president of many societies, including the first North American president of the International Society of Pediatric Hematology Oncology. And so it is a great honor that Mark is with us and that we are able to celebrate his incredible career and the impact that he has had on the field of pediatric oncology. And what is even more special, I think, for all of us is that Dr. Les Robison is here today as our 22nd lecturer. Les is a dear friend to us. Les actually originally started out in California and got a training in initial undergraduate in public health, and then moved here in 1979 to do a master's in public health and a PhD in public health and epidemiology. And rumor has it that Mark was part of the reason that Les came and stayed. And so a relationship began in the early 80s between Mark and Les that continues today, that is very strong, and they're very dear friends, but also incredible colleagues. And together, they really built the field of leukemia epidemiology and the cooperative group structures that we now know today. And Les was sharing with me last night, and that Mark at the end of every day would ask him, what did you learn today? And what was the most important thing you experienced today? And I think, Mark, if all of us ask that question at the end of every day, I think there is a lot to be learned every day, and we continue to learn and we continue to grow. And thank you for that legacy. Mark's commitment to that philosophy is fostered by this lectureship, which is focused on the training of our fellows and the continued education of all of us, part of this grand rounds and part of the symposium that we had together. So Les, to continue on Les's journey, Les in 2005 left here after being head of pediatric epidemiology here, and after having founded the Childhood Cancer Survivor Study, the largest study ever to look at survivors of childhood cancer. And he moved to Memphis to take over a very large program at St. Jude, really continuing the work in childhood survivorship. Les has been continually NIH funded for a couple decades, has authored and co-authored more than 400 publications in peer-reviewed journals, and is literally probably the world's expert in childhood survivorship. And it is a tremendous honor to have Les here, and also a tremendous honor for us to celebrate this with Mark. It's a very special day for us, and thank you, Les, and we look forward to hearing from you.
Thank you, Brenda. Indeed, it's my honor to be here, especially for the Mark Nesbit lecture. This is a very important piece of history here at the University of Minnesota, and a very important part of my history. And so what I want to do today is, first of all, set the stage a little bit in terms of long-term survivorship and how we got there. And this is a slide that I use in almost every talk that I give, and it takes data from the Surveillance Epidemiology and End Results program at the National Cancer Institute, and which started in 1974 and is probably one of the best population-based sources for cancer incidence and outcomes that we have. And so we use this. We can estimate how many cancer survivors there are in the United States, pediatric cancer survivors specifically. And right now, in 2013, we estimate that it's starting to approach close to 400,000 that are actually diagnosed and are now surviving. And this is great, and we can look at it, but it's only a very small piece of, I think, what is important for us to recognize, and that is how did we get here, and how did we get there? And the best data that's available would suggest that prior to 1970, the overall survival rate of childhood cancers in the United States was probably somewhere in the neighborhood of 20 to 25%. And this largely represented survivors who could most successfully be treated with either surgical procedures or combinations with radiation. But what you can see here is, from 1960s up to the 70s, there was a dramatic increase. And that increase came in a number of ways. And one of these was through the treatment of the most common childhood cancer, which is acute lymphoblastic leukemia. And these are data from the legacy group of the current Children's Oncology Group, the Children's Cancer Group. This is the group that Brenda mentioned that Mark was very instrumental in establishing and building over many years. And this gives you a little bit better sense of how that progression actually took place for just one type of malignancy, and this was ALL. And as you can see, that there was a trial that very specifically, the CCG 101-143 trial, which was chaired by Mark. Mark was the PI and the major move behind this very significant landmark study in childhood ALL that essentially took the long-term survival rate from 20% to almost 60%. And if we think about research that's being carried out right now, how many examples do we have where somebody in a single trial could impact the outcome in such a major way? Not only did this trial improve survival, but it also laid the foundation on just numerous aspects of the treatment of childhood leukemia. That trial actually designed specifically to evaluate differences in terms of central nervous system prophylaxis, demonstrated that minimal IT methotrexate wasn't sufficient to prevent CNS relapse, but it also demonstrated that you could go from 2400 to 1800 centigrade and still provide adequate protection of the central nervous system. It provided the foundation for reduction of length of maintenance. This trial randomized between 3 years and 5 years. So up to that point, children with ALL received 5 years of maintenance therapy. Mark's study showed that you could go down to 3, and moreover, provided the first evidence that there was a difference between males and females in terms of the required length of maintenance to go forward. Lastly, this one single trial also was the basis on which risk stratification started. This was the study that identified the prognostic importance of age and white count and a number of other clinical parameters that started to allow one to identify low risk, intermediate risk, and high risk patients to start to tailor therapy as we currently know it as we go forward. So this is one example of Mark's input. But when we go back to this original slide, it goes beyond childhood ALL. Mark was instrumental in other diseases, including the intergroup Ewing sarcoma trials. This was a major undertaking to bring together essentially all of the cooperative group entities to bring together cases of Ewing sarcoma for future study. Histiocytosis, also a major leading area. But also Mark was the PI of the first national clinical trial that integrated bone marrow transplant in a randomized fashion into the treatment of childhood AML. So it wasn't just one study, it was multiple studies. And it wasn't Mark, although it was Mark's leadership without question, but it was also a legacy of the University of Minnesota that's just phenomenal, going from Bob Good, Bill Crivet, John Kersey, Norma Ramsey. I mean, you have just an unbelievable group and history here that got us to that curve that most of us now use. And it's important to remember that actually was a major piece of what we're going to talk about today, which is survivorship. How we got from a long-term survivorship of 25% to 60 to now over 80% that we see in the general population. Now, when we think about survivorship, obviously there's a lot of components, and most often we focus on the treatment. What are the treatment parameters? Radiation, chemotherapy, surgical procedures, but also there's other issues in terms of tumor location that's going to certainly drive risk of late effects, and also some of the acute events that happens during the treatment that may translate into long-term complications. But it's really a much more complicated picture to understand. There are so many issues and factors that can come into play in dictating the occurrence and risk profile for long-term consequences of the treatment, anywhere from the genetics, both the major genes as well as the genetic polymorphisms that relate to transport of drug, metabolism of drug, repair of damaged tissues, and so forth. Premorbid conditions the patients may have come to with prior to the diagnosis. Host factors, age, sex, very important in terms of time of exposure. Subsequent health behaviors as well as aging. So really what it is, it's very complex and it's very multifactorial. And when you think about that, if you start looking at just one component, you're going to learn, you might learn something, but you're not going to learn the whole picture. And so in order to understand the whole picture, you need large populations, very heterogeneous populations, to be able to start to understand what some of the different treatment parameters might be, the biologic parameters, as well as the subsequent health parameters. And that's really what led to the establishment of the Childhood Cancer Survivor Study. Here at the University of Minnesota, it was under Mark's division head directorship that this study was really supported, promoted. It was individuals like Joe Neglia and others that actually came together as a team to say, how can we build something that's going to overcome those barriers and really inform what the long-term consequences are for this population in the most informed and scientifically rigorous way. And CCSS has been remarkably successful. It's been funded for almost 20 years now continuously. It's been the largest single source of late effects data anywhere in the world, over 200 peer-reviewed publications from it. And so it's really been incredible. And again, it was the legacy of the University of Minnesota that really had the insight to bring together the people and the resources to start to build this type of infrastructure. Another legacy, though, of CCSS is that it was one of the first studies which has now led to the proliferation of multiple large pediatric cancer survivor studies, including the group in Vancouver, the Kayaks cohort, the British Childhood Cancer Survivor Study, which is modeled exactly after the CCSS, the French-UK cohort that's been followed for quite some time, the Swiss Childhood Cancer Survivor Study. There's also the New South Wales cohort in Australia, as well as activities very directed by the Pediatric Oncology Group of Ontario. The Netherlands is now organizing to put together a nationwide cohort of childhood cancer survivors. The Danes also have their survivor cohort now. And the entire European community has come together with a PanCare consortium that also addresses childhood cancer survivor. And this was all built around the CCSS and recognizing what we could learn by bringing together large numbers of patients, large number of investigators going forward. So today, actually, what I want to talk about is not CCSS, but rather another cohort that my colleagues and I have been spending a great deal of our time on over the last 5 to 6 years. And this is the St. Jude Life cohort. My colleague, Dr. Melissa Hudson, is the principal investigator of this protocol. And as you can see here, this includes a very unique cohort, and that is this is a clinically followed cohort. Where many of the others that I've discussed with you are through surveys, self-report. This is a clinically assessed group going forward. The eligibility includes all survivors of childhood cancer ever treated at St. Jude since it opened in 1962. The eligibility is that individuals have to have survived at least 10 years and be over 18 years of age to enroll in the St. Jude Life cohort. This criteria is used because that's actually the criteria at which patients are transitioned out of St. Jude in terms of their care is no longer being provided by St. Jude. It's being transitioned back to their community physicians. As I mentioned, it's a clinical cohort, so it's retrospective. We went back to everybody that had been diagnosed. It's also ongoing, so as a patient meets this criteria, they're automatically now enrolled into the St. Jude cohort. And it's also a prospective study. So as of May, right now, we have a little over 4,400 eligible individuals, of which about 3,500 have already agreed to participate in this follow-up. And we've completed on-campus visits and clinical assessments for about 2,600. And using the data that we have available right now, we're looking at overall participation rates of 70 to 75%, which is quite remarkable, frankly, in terms of getting a group to come back to undergo a rigorous clinical evaluation. The participation of these individuals include, first of all, completing questionnaires before their clinical visit. It's followed then by an on-campus visit, which utilizes as the basis the Children's Oncology Group long-term follow-up guidelines. These are risk-based recommendations on terms of what the screening and follow-up of pediatric cancer survivors should be. It's augmented by a core battery of assessments that we carry out. And then on top of that, many of the researchers have specific research protocols that individual subgroups are eligible for. So when a patient comes for a St. Jude evaluation, it's a minimum of 2 days on campus. The average is actually 3 to 4 days and can extend up to 5 days. So this is a very significant and very rigorous assessment of patients as we go forward. For those enrolled, the frequency of evaluation prospectively is determined by 2 factors. One, the risk profile. So those at highest risk we bring back on a more frequent basis versus those that are at low risk. And then also research protocols that individuals may be eligible. So that sort of dictates as we go forward. With the level of participation, we can only see about 1,200 patients a year on this protocol because of the intensity of evaluations in the clinic and the schedulings and so forth. So we have to be very careful in terms of how we bring folks back. So what I'm going to do in the time that I have right now is just give you a few ideas of the type of data that a clinical cohort like this can generate. It's taken a long time to build it, just as it took us 6 years in CCSS. For the first 6 years of that study, we didn't publish a single paper. It's a little hard to do to go in for a competitive renewal at 5 years saying we haven't published anything yet, but establishing cohorts it's an investment. It takes a long time before you can actually start to see the yield, and we're just now at the point where the St. Jude Life cohort is starting to provide that data and feedback. So I'm going to give you just some examples that will not only tell you about the overall findings, but also some very unexpected findings, some new information that's been gleaned from this clinical evaluation. So first of all, just talking about the overall prevalence of chronic health conditions and what do you yield if you actually bring these survivors back and you evaluate them, you screen them extensively, so the yield of risk-based screening. The first overall publication is currently in press in JAMA. It'll be in the June 11th issue. We used the first 1,713 individuals that had participated in the St. Jude Life. Their average age, or their median age, was 32 years. Median time from diagnosis was about 25. But you can see the ranges. So these range from 18 to 60 years of age. And also time from follow-up from 10 years to 47 years from the original diagnosis. And the diagnoses are listed here, and it's not the typical distribution that you would think of for pediatric cancers. It's much more heavily weighted towards leukemias and lymphomas, which is part of the history of St. Jude. It was very early, very focused on childhood leukemia. But also we enriched our recruitment process to enroll those individuals earlier in the study because they are the older and the longest followed group. And so we purposely brought them into the study a little bit earlier. But we do include in this group all diagnoses, as you can see. The punchline from the first part of the publication is that when we look at this group overall, we can estimate that at 45 years of age, 80% of the cohort that we see actually have a serious, disabling, or life-threatening chronic health condition. This is graded according to the common terminology criteria for adverse events from the NCI. That's a grade 3 or 4, 80% by 40 years of age. And if we look at any chronic health condition by 45 years of age, 95%, approaching 100% of this population, have at least one chronic health condition. Oops. So let me just give you a few examples of what we can kind of see. And let me orient you on these slides very quickly. So the blue, these are according to cumulative prevalence according to age. The blue line represents what the prevalence was prior to their enrollment or joining the St. Jude Life cohort. So this is very much in terms of what had come to clinical detection, what their physicians had found, and what they had previously been diagnosed with. The red line represents what the cumulative prevalence was after we evaluated them. So essentially the difference between the blue line and the red line is the yield from risk-based screening. So if we actually evaluate these survivors, this is how much morbidity we were able to identify that hadn't yet come to clinical detection. So we had some great discussions this morning and talking about metabolic syndrome and issues and looking just at dyslipidemias, for instance. You know, according to this slide, you can see that we are estimating that between 50 and 60 years of age, almost 100% of these childhood cancer survivors have dyslipidemia. And that's so much higher than we would expect in the general population. It should be high, but it's not that high in the general population. If we look at males and females, just in terms of gonadal function, Leydig cell failure, you can see very marked differences between what was previously been diagnosed and what the yield was. But if we look at this also in terms of what part of the disease process might be attributable to their prior cancer therapy, because obviously somebody can have dyslipidemia and it may not have anything to do with their cancer treatment. It may just be to their genetics or how they eat or their lifestyle. So what we can do is actually calculate the attributable fraction. And the attributable fraction is based on the information, again, from the COG guidelines that says here are the factors that we know are increased risk. So if we look at these top three, for instance, primary ovarian failure, hypothyroidism, Leydig cell failure, you can see that the calculated attributable fraction is incredibly high. So the way you sort of interpret that is that of the individuals that had primary ovarian failure, 100% of them had either received alkylating agent therapy or radiation to the ovaries. We saw no one that didn't have those exposures that had primary ovarian failure. So these actually, the treatments that we've already identified, probably are pretty good in terms of accounting for the vast majority of the outcome that we're going to see. Whoops. Let's just see if we can get rid of that. But let's look at some of the other. Let's take the dyslipidemia example again, though. Based on this, only 15% of what was observed can be attributed to the treatment-related risks that we know. So that's telling us one of two things. Either we haven't identified some of them, or a very large part of this is coming from just the background in the general population, or indirectly through some other treatment-related abnormality that's impacting on lipid levels. So you can see from this, and again, hypertension is another one where there's actually quite a low attributable fraction, but quite a high prevalence. Now let's go to some of them that are more risk-based very quickly. Abnormal pulmonary function. This was, again, only in the 417 individuals who had received either bleomycin, nitrosourea, busulfan, lung RT, or had a thoracotomy. Those are the risk factors that are known to impact. But if you look just within those groups, again, we're starting to approach 90 to 95% are going to have an abnormal pulmonary function studies by 50 to 60 years of age. Hearing loss following platinum-based therapy or radiation to the ear. The same thing you can see, very high expected prevalence rates by the time we get to 50 or 60 years of age. And again, in terms of the yield, you can see that most of this follow-up where these lines overlap is when the patients were part of the after completion of therapy clinic. And this is when they're released from the hospital. So you can see that if we just go based on what has been already diagnosed or self-reported, it's relatively low. But when we actually study them, it's quite high. Secondary breast cancer for females who've had greater than 20 gray radiation to the chest. You can see the yield again. And the vast majority of these breast cancers were detected at their St. Jude Life study. A few after they had gone back to their community, but the vast majority, these were individuals who with routine mammogram and breast MRI, we identified breast cancers. Cardiomyopathy, for individuals that received anthracycline or heart radiation to the heart, you can see the increased yield. Heart valve disorders. Look at this. In the 501 patients who had heart radiation involving the heart, we estimate, again, between 50 and 60 years of age, almost 100% have an abnormality in terms of a heart valve. Some severe, some not quite so severe. But I'll show you some data a little bit later that probably might suggest that even those that may not be graded as severe might actually have implications. And then lastly, pituitary function. That's the other flip side. Most of those had already been diagnosed. Those were being picked up either because of clinical signs and symptoms or routine screening. TSH levels, LH, FSH that are being done and carried out in the usual healthcare setting. So the vast majority of those patients had already been picked up. So screening them in a late effects clinic really didn't yield anything for us. So let's go in terms of, quickly, a very one-time study in terms of, we looked at cardiomyopathy and the increased prevalence. Within this cohort, we can actually study different approaches in terms of how do you evaluate cardiac function. So here, Greg Armstrong had an ASCO Career Development Award where he looked at comparing standard echocardiography and cardiac MRI in terms of the ability to pick up abnormalities. And typically, these patients are being screened by 2D echo. You can see that in this population, again, these are people that were asymptomatic, had not been diagnosed with any level of congestive heart failure, that we identified 14% that had an ejection fraction below 50. But the sensitivity, using MRI as the gold standard, the sensitivity of 2D echo was only 25% in this population for identifying cardiomyopathy. And more importantly, 12 or 11% of this population, based on 2D echo, actually were graded as having what would be considered a normal ejection fraction, when in fact on cardiac MRI they may have had an ejection fraction closer to 40%. So this is telling us that actually within this population, it may be that's a very high risk. We may not be catching the whole thing if we want to catch them early in particular by using standard 2D echo. Endocrine dysfunction is a major issue within the survivor population. It's one of the more common late effects that one actually sees. Within this group, looking at the first 2,240 in terms of some looking specifically at anterior hypopituitism. Again, median age of 31, about 25 years from diagnosis. Number of diagnoses, you can see that everybody's been evaluated, but the group that we're most interested in right here are these 822 who had actually received cranial radiation. And within that group, studying them as adults, almost 50% were found to be growth hormone deficient as an adult. 11%, almost 12%, had LH or FSH deficiency, and as you can see for TSH deficiency or ACT deficiency. But overall, we can start to identify the risk associated with the dose. And some of these risk levels are really quite striking, as you can see that, for instance, even with TSH, out here, we're starting to see risk levels in the 60 and 70-fold at some of the higher doses. But it's this group, actually, that I should mention that this doesn't show the linear relationship that we probably expected to see. But part of the problem is that not everybody is screened for growth hormone deficiency, according to the guidelines, because of the cost, obviously, that's involved. So we only evaluated those that had cranial radiation. So the referent group is actually those with the lowest dose of cranial radiation. But this is an interesting group in many ways clinically. If you look at growth hormone deficiency in the general population, it's certainly associated with a number of issues in terms of subsequent health risks, cardiovascular risks in particular, loss of muscle mass, loss of bone health, and also an emerging literature that basically says some of these adult growth hormone deficient individuals, again, not cancer survivors, also have a lower quality of life. Well, one of the things we could very quickly look at within our population who had growth hormone deficiency as an adult, looking at quality of life using the SF-36, we actually found no data that suggested that those that actually had growth hormone deficiency as adult were reporting to us lower levels compared to even when we look at those that had cranial radiation versus those that didn't have cranial radiation. So telling us that supplementation with growth hormone within this population may not be the way to overcome the quality of life issue. Certainly some of the cardiac and other issues could be intervened using approaches other than growth hormone supplementation. Frailty. Frailty is an area that one of my colleagues, formerly here from Minnesota, again, Kiri Ness, has been quite interested in. And frailty is typically a phenotype that you equate with old age. And one of the things we're very interested in cancer population is, are we actually seeing an accelerated aging within these cancer survivors? So Kiri has been looking at this, and so the frailty phenotype, very quickly, you can distinguish it between disability and comorbidity, but it's very predictive of subsequent risk of hospitalization, risk of morbidity, and it's actually very predictive of mortality in the general population. And you can identify it using five very relatively easy indices in terms of looking at lean muscle mass, exhaustion, energy expenditure, walking speed, and muscle weakness. So frailty is a well-established phenotype. And she was interested in looking at it within our survivor population. And what you can do is you can look at these, and basically the definition, if you fulfill 2 of these, you're considered pre-frail. 3 or more, you're considered frail within the group. A population, again, mean age about 33. Well, these are the data that you actually look at in these childhood cancer survivors. And as in the general population, females are more likely to be frail than our males, so the sex difference wasn't unexpected. But you can see that in the female group, 13% had frailty, 31% pre-frail, 2.7 in the males and 1.2. But if you look at these prevalence rates, these are very similar to what you see in individuals in the general population over 65 years of age. This is a cohort that's 33 years of age. So we're looking at a group that actually are showing physical aging at a very young age. But here's also the thing that's actually she's very interested in, and this is actually being proposed as a prospective evaluation, is, first of all, we don't see it equally along our types of childhood cancer survivors. The highest frequency we see are actually in our brain tumor survivors and soft tissue sarcoma survivors. But even in this small group at St. Jude that's been prospectively followed now, with an average length of follow-up of about 3 years, you can see that frailty actually predicts the risk. That is, those that are frail at baseline had a 2-fold increased risk of developing, again, a grade 3 or 4 chronic health condition, a severe or life-threatening chronic health condition within 3 years. That's pretty strong. And then if we just look at the overall mortality from their baseline assessment in St. Jude Life, we see that those that were actually frail, and this again adjusts for other chronic diseases that already existed, are almost 2.5 times more likely to die within a median follow-up of 3 years. We don't see a significant difference in females, but look at the males, 6-fold. Even though the males have a very low prevalence of frailty, those that were frail were 6 times more likely to die within a relatively short time period after their baseline evaluation. So we think that actually frailty might be a very important approach in terms of gauging at-risk populations as we go forward. It certainly will identify a group that might be intervened upon at an early time period. And so we're going to be pursuing this as we continue to follow these patients. Pulmonary hypertension. Here's a finding very quickly we didn't expect to see. I mean, you don't actually see pulmonary hypertension as one of the major late effects of therapy. But what happened was, as we were doing the echocardiograms on the patients who had received anthracycline or cardiac-directed radiation, the cardiologist started saying, we're seeing a remarkably high number of individuals that have elevated levels in terms of the tricuspid regurgitant jet velocity that they can measure off of the echocardiogram. And TR jet velocity is actually a relatively good predictor in the general population of pulmonary hypertension. Individuals that have elevated levels, say above 2.8, somewhere between 60 and 70% probably have the diagnosis, actually have pulmonary hypertension, which is extremely important because, again, pulmonary hypertension in the general population is associated with an incredibly high risk of subsequent morbidity and mortality. So essentially, this was an analysis that included 498 survivors. This was published this year in JCO by Greg Armstrong. And basically, when we looked at this overall group, and again, using a breakpoint of 2.8, which is a pretty high level, it's a high bar in terms of saying this is an elevated TR jet velocity, overall 15.1% met this criteria. And you can see that the prevalence actually increased, and the Hodgkin survivors were those that were actually at the highest risk. And when we looked at the dose response in terms of the amount of radiation that was received, chest-directed radiation, again, you can see a dose-response relationship, prevalence increases, so that those individuals that received either 20 to 30 gray or 30 or more gray had somewhere between a 4.5 and a 5.5-fold increase of actually having some suggestion that they have pulmonary hypertension. So we're right now in the process of just starting a pilot study to bring back 20 of these individuals to do heart catheterizations on them. Actually, heart catheterizations will be carried out under stress test situations. So they're on a recombinant bike, so their heart is being stressed at the time that they're doing the catheterization to try and understand what the etiology of this is. Is this on the pulmonary side? Is this more on the cardiac side? So that we can start to figure out, is there a way that we might actually be able to detect and intervene early with this group? Lastly, and I'm running out of time here, I'm going to go through this kind of quickly. Neurocognitive outcomes. I know it's an interest very much here at University of Minnesota, and it is an area that's certainly impacts significantly the outcomes and the quality of life of these survivors. So my colleague Kevin Kroll, our neuropsychologist, has been evaluating all of these patients with his team. And there's a number of issues that obviously we're interested in terms of we know that cranial radiation impacts in terms of neurocognitive deficits, but we don't know what that is going to mean 3 decades, 4 decades, 5 decades later. And so that's one of the issues. We certainly are interested in whether or not there's some threshold effect in terms of the dose of radiation, or is it linear as we go forward. So these are some data that have been submitted for publication, which look at a little over 600 survivors of ALL. And we have a group that had received no radiation, some that 1,800 and some that 2,400 centigrade. It's important to look at the current ages of these groups, and they're not the same because the 24 gray group is an older group, followed by the 1,800, followed by the non-irradiated, who are the more recently treated group. So you can see that there's certainly a time issue in this. But also, when you look at this, the amount of methotrexate that these patients receive differs substantially also, in that, in particular, those individuals that didn't receive cranial radiation, they're certainly receiving much higher doses, cumulative doses of methotrexate, both intrathecal as well as systemically. This is the battery, which I won't go over, but it's a very rigorous neuropsychological battery that this group goes through. And here's just a summary, again, stratified on their current age. So these are less than 30 years old, 30 to 35, and these are individuals who are over 35 years of age at the current time. We don't have enough non-irradiated group in that group, age group, to be able to follow. But you can see very much that individuals who are severely impacted on a number of domains ranging from intelligence to memory to academics, processing speed, executive functioning, that in fact, as we go out, it's very high, upwards of 30% of some of these populations. It certainly varies. It's higher in the 2,400 than it is in the 1,800, than it is in the no irradiated group. But it's important, look at this non-irradiated group. Look at the proportion that are still showing neurocognitive deficits. Very likely because we're trading off some of the late effects from radiation with the increased exposure to methotrexate. What we also can start to see then is, again, some of the age-related issues. This was age at diagnosis. And again, what we have known before is that, in fact, with many of the radiation exposure, younger age is going to have a more severe impact. But look at down here for intelligence, 1,800. Look at the difference between 1800 and 2400. We see relatively no age effect for the 1800 group. And then when we actually look at time from diagnosis, again, we start to see some issues. This is for attention and executive function. Some of these 2400, we can see extremely high increased relative risks compared to no radiation, almost 20-fold. But again, down here, looking at executive function in those that received 1800, we don't necessarily see increasing time as it goes on. This is clearly suggesting to us that there's probably more to 1800 versus 2400 than simply a linear change. And the way that much of this has been looked at, these are two different papers that one's that Greg Armstrong published this year in JNCI and Kevin Kroll has in Press in Blood, where we looked at this in a much more rigorous way to look at these neurocognitive outcomes, mostly interested in issues relating to memory. That is underneath the hypothesis. Are these survivors who have had treatment that affects their neurocognitive abilities, will we actually see an early onset of dementia within this group as they age? Will, again, this premature aging phenomenon affect the neurocognitive function? And so what we did is we looked at 265 ALL survivors, all of whom received cranial radiation. And a random subset of those, we actually did MRIs on them to look at white and gray matter volumes, hippocampal volume, cortical thickness, diffusion tensor imaging, as well as functional MRIs. And one more piece of data about if we just look at memory in terms of immediate memory and delayed memory, you can see that within the 1800 gray, and this is all adjusted for age, so it's not an issue that some are younger than the others. The 1800 group are actually functioning right where we would expect them in terms of the proportion, in terms of the proportion that are under one standard deviation. But in contrast, the 2400, we see very elevated levels. So again, another indication that maybe 1800 is a bit different. I'm going to do this really quick because you can look at the paper that was published just recently. When we start looking at volume in terms of immediate memory and temporal lobe volume, significant differences in terms of the volume in those that were impaired and unimpaired. When we look at hippocampal volume, right hippocampus is where we see significant differences, and that also goes along with what we would expect in terms of some of the memory issues. And also when we start to look at cortical thickness, we see those that are impaired show significantly greater reduction in terms of cortical thickness. So when we look at this in aggregate, when we're looking at individuals, overall, they see, in terms of the memory domains and the function, they seem to be functioning at a cognitive level that's somewhere between 1 to 3 decades beyond their chronological age. And that when we look at the individual parameters and we relate this to dementia and normal aging, it all fits very consistently in terms of fitting a model that, in fact, these individuals may be having neurocognitive aging accelerated because of their exposures. And lastly, I'll end with one more unexpected finding, which gets to neurocognitive function. I think many people know that Hodgkin survivors quite often report a very high rate of fatigue, chronic fatigue, that goes forward. So we were interested in just doing a brief neurocognitive assessment, well, an extensive neurocognitive assessment in a small group of Hodgkin survivors to see if some of the fatigue actually translated into poor neurocognitive functioning. Tired people don't function as well. Well, so what we did is we started to find something very interesting, and which expanded into studying 62 adult survivors of Hodgkin's lymphoma. Where, again, this is a group that their current age, median of 42 years of age, 27 years from diagnosis. We did imaging studies, and here's basically a representative scan that we found. We found a very high prevalence of multifocal leukoencephalopathy within this group, as well as multiple instances of hemosiderin deposits. So basically some suggestion that, first of all, there's been either an infarct or some bleed, as well as evidence that typically one would see in maybe a scan like this might look like in somebody that's 80 or 85 years of age. And what we found is that, in fact, this is stratifying according to the dose of mantle field radiation they received to the chest. So these patients don't receive any CNS-directed therapy. It's all to the chest. So you can see that, in fact, the frequency of leukoencephalopathy was in those that had greater than 30 gray, 64% had evidence of abnormalities on MRI. Same thing you can see with hemosiderin. But also, that's the group that we've already known, and in this group in particular, they also have very high prevalence rates for abnormal cardiac function as well as pulmonary function because of the mantle fields and the dose of radiation that they've received. So when we looked at this, basically in terms of their neurocognitive function, these all correlated. So this is basically looking at working memory, task completion, fatigue. You can see those that have abnormal systolic function are the ones that are scoring the lowest on these neurocognitive parameters. Similarly, over here in terms of pulmonary function, those that had an abnormal DLCO also scored significantly lower on issues of sustained variability, speed. So in essence, we're seeing cardiac and pulmonary function correlating with their neurocognitive function. And so basically the model that Kevin has put forward now, and this has just been recently funded as a 5-year R01 to actually study about 400 Hodgkin survivors to better understand what's going on, is that, in fact, thoracic radiation results in cardiac and pulmonary dysfunction, which changes cerebrovascular function, which we see as multifocal encephalopathy, hemosiderin deposits. I didn't show the data, but we also have data showing that they actually have thinning of their cerebral cortex. This impairs them neurocognitively and also impairs them then functionally as adults. So in essence, what this is telling us, a new finding, when you're thinking about neurocognitive issues, you've got to start thinking about other mechanisms. And is it in fact the hemosiderin deposits, are they occurring because of that high rate of valvular disease that we're seeing in those that had chest radiation? Are they forming small clots, throwing them to the central nervous system? Is the pulmonary dysfunction resulting in some very modest, low-level hypoxia that's extending over time? So the bottom line is these are just some examples of studying a clinical cohort over time, but these are observations. What we have to do now is take these observations, and what we are starting to work with, take those observations, those individuals at high risk, and keep going there, how they impact the current follow-up and clinical guidelines for this group, but also to start to develop how do we intervene, how do we change it, not just in terms of the initial treatment that new patients receive, but how do we intervene on the current population. So with that, I just want to end this presentation by going back to a little bit of history again. As Brenda said, I did my PhD here at the University of Minnesota, and this was my thesis, which was completed in 1982, and it was on follow-up study of long-term survivors of childhood acute lymphoblastic leukemia. This was Mark's 101-143 study, and at that time we thought we were being really great by saying long-term follow-up. These were followed for 7 years, and this was the study that we had. And obviously, it's continued, and it's really driven my career. And in all the thesis, you always write an acknowledgement, and part of my acknowledgement was the contribution that Mark had made, not just to that study, but to my training and my mentoring. And little did I know that was the starting point. It's gone on now for 20, 30 years. So thank you, Mark. And with that, with a little bit of time, we toast each other. I'll be happy to, if there's time, to take a few quick questions. Thank you very much.
And thanks to Les for an incredible talk. And I'm hearkening to a comment Mark made this morning, is that when all of this started, and still what I do every day is I just want to get them to survive. And now I'm really worrying because there's a lot that's going to happen after that, and incredible food for thought, and incredible opportunity. And I think the other thing is that this wonderful talk exemplified a career of focused investigation in an area and where we've come, and it's incredible and an incredible example. And I know Joe has lots of questions, so go, Joe.
I'm going to ask you Mark's question.
Okay.
So after 30 years of doing this, what do you think the 2 or 3 What are the really big, what's the really big things that have changed?
Well, actually, I think the biggest ones are going to be the cardiovascular. And the data are certainly emerging that's translating into the mortality issues. And so I think understanding, and it's not just how much treatment they received. So one of the papers that's currently submitted for publication right now that shows that these survivors who had either anthracycline or chest-directed radiation, if they have a certain level of risk for cardiac events, either congestive heart failure, myocardial infarction, but if you add on top of that some of the other risk factors that Julia and others are studying in terms of lipids, hypertension, obesity, what does that do? And we've got a paper right now that actually shows that that's the tip of the iceberg. That sets them up. So if you basically take somebody that's been exposed to those and they have hypertension on top of it, their risk of a subsequent event is much more than adding the two together, having hypertension alone or anthracycline-induced exposures. It's not quite multiplicative, but it's significantly more than additive. So in essence, I think what we're learning is the big take-home message is, yes, there's major impact, but the bigger issue is much of this exposure are setting up patients for major health events that are going to be added onto by lifestyle sorts of issues, which then gets back to the second one, which is we have the potential to intervene if we can potentially change some of those issues, some of those behaviors, smoking and diet and exercise, which are tough to change. But if you've got a really high-risk population, it's worth really going after it. So I don't know if that totally answered second malignancies. There's a whole lot of but also understanding some of the underlying biology, too. I mean, the effects, how radiation actually impacts and affects some of these organs, how anthracyclines are actually working in terms of the damage and where they're damaging and how we might actually catch it at an earlier age.
Les, that's a fascinating talk, and thank you for giving it here today. I want to follow up a little bit on the cardiovascular part. I was surprised that there was such a wide difference between the echoes and the MRIs and so forth. Has anybody, or is it even ethical, to think about biopsying the myocardium in those individuals to see what they look like, those so-called sub-echo abnormalities?
I don't know if you could get away with doing biopsies at this point, but I do think that it starts to tell us that, I mean, when we did the MRIs, the cardiac MRIs, we also did some of the contrast and so on to see could we actually identify areas that actually were more severely damaged, and there was no relationship. Actually, we didn't see any that really wasn't informative.
It's almost going to be histologic.
It really is. And I think that the important part, though, with the cardiac and the cardiac screening is we've got to get them before they pass that threshold of cardiac decompensation, because, yeah, you can start to give them beta blockers and ACE inhibitors, but that's not necessarily going to result in any degree of remodeling that's going to get them back to a normal level. So the idea is if we can get them at an earlier stage, potentially before they go from that 55 to 50, cross the 50 threshold, and say that's when we need to intervene. That's when we need to put them on carvedilol and start, to hope that we're going to stop that progression before they get too far. So I think that's why some of the imaging. What we're actually doing right now is we're getting ready to act upon this in our own population. So anybody, we use 3D echo in screening, so the sensitivity is a bit better. But anybody that actually has an echo ejection fraction between 50 and 55, we're now sending them to cardiac MRI to actually see, just to feel comfortable that in fact we've got them at an early enough stage, and then we can start to follow them annually to see are they changing, are they going to start to decompensate.
I'm surprised you didn't say stem cells in that long.
Yeah.
I think it's in 1974, we published the data, I and Mark, that showed that 12 gray was probably as effective as 24 gray. We just couldn't convince CCSG people. They were so afraid of just reducing dose. So this 18 gray was not based on any scientific data. It's totally political compromise.
Well, it was political compromise, and I think part of it was Mark's gut feeling, too, that less is going to be better than 2,400.
Yeah. So this thing happened way back, but I still wish that we should have tried 12 gray.
Okay.
Yeah.
Thank you, Ty.
That was very nice, Les. On the pulmonary function itself side, do you see restrictive disease or is it obstructive dominating in this group?
In some of it, it's a combination. It's depending on I think, the part of the etiology. Is some of it is fibrosis, and we see very high levels of fibrosis in some of the bleomycin treated and some of the irradiated piece of it. But the pulmonologists and folks are working on this. Actually, all of these areas that I touched upon in general are right now being extensively analyzed and evaluated as we go forward. So it's not predominantly one or the other that I've seen the data on thus far. That we think there's going to be multiple mechanisms, and the severity also is quite a large spectrum.
The low DLCO is interesting, and that's mostly a reflection of the amount of hemoglobin going through the lung per unit time. So that suggests central ischemia could be part of the problem and proximal problems with the vessels. Yeah.
Hi, Les. I think the fascinating thing about this is that these adverse effects are occurring gradually. So that suggests that and you would think if it were the treatment, only the treatment, that something would happen acutely and you'd see it acutely. So it would seem that something is perhaps happening in response to the treatment, but then natural aging on top of that, as you suggested, might be doing it. So my question is, do you think there's any way to prevent this?
We hope that's ultimately what we're going to get to. And obviously one of the main ways to prevent it is to minimize the amount of exposure up front. That's resulting in some of these. But certainly there are going to be areas, some is going to be unavoidable. I don't think, if you're going to truly cure the cancer, some of these agents are just critical to the fact that you've actually cured them. So I don't think that you're going to be able to prevent the occurrence. Now, can you prevent the severe morbidity or mortality that comes with it? That I think we have a lot of venues and a lot of opportunities if we can figure out when we can catch them and then start to test. And we have to test it, I think, in clinical trials, whether some strategies are going to actually be effective. So, for instance, we have a trial right now where we're using low-dose tamoxifen in women who had chest radiation for prevention of breast cancer. We're using carvedilol in individuals who have normal cardiac function, but they received high cumulative doses of anthracycline in the hope that it'll actually prevent the deficit from occurring in terms of ejection fraction. So we're testing these in placebo-controlled trials very early on, and are they going to be successful? But I think that's the goal of all of this: is can we intervene?
All right, Brad, and then Julie will get last question. Oh, Mark.
Yeah,
All right, Mark. Sorry.
Oh no, this is the question I'm probably most afraid of.
I want to comment on one thing. When I started doing my pediatric oncology thing, and when I was in charge of the children with the cancer, we did some early studies, and it was these early studies here at the University of Minnesota that we did, that I then put into the studies that was in the United States. and I only want to comment is that what the study was with Dr. Sharp was one of the two, there's three of us that did this study. And so he was kind of responsible for a lot of this that happened, even though he went into some other field. So I have to, people don't know that. The question I have is, there is a question of people that have OPTD, and there was going to be a study where you would sit on something that vibrated, and that would decrease your rate.
Yes.
Do you know anything about it?
We do. Actually, the study wasn't for obesity. It was actually for bone density, but there was data that suggested that people who have high-frequency, low-impact vibration actually would lose weight also. So that's the part you picked up on. But the study itself was actually to see if you could use this in the leukemia survivors who actually have reduction in bone density because of their treatment. Could we actually increase it? And the study was again a randomized trial. It's over. The data is actually being analyzed. There is a disappointingly modest increase in bone density among those that for 1 year underwent daily low or high-frequency, low-impact vibration. So it didn't impact the way that we had hoped it would.
What about weight?
I haven't seen any of the data, but if it didn't help their bones, I'm not quite so sure it would have helped their weight. So I haven't seen those data, but I have unfortunately the increase in bone density didn't materialize.
I know we're a little bit over time, but we've got two hopefully quick questions, and we'll be.
So my question is quick. It was following up on the pathology and the biopsy question. Is there a concerted effort to obtain autopsy specimens on your cohort for the patients who do pass?
No, we don't, unfortunately, because most of these we hear about because they go back. They're all over the country, and unfortunately we haven't. One of our biggest issue right now that we're focusing on is actually getting pathology on second tumors, fresh frozen material, so that when we know somebody's going for biopsy or for surgical resection, we try to organize and actually get fresh tissue. That's incredibly challenging also, but it's a great idea, but we haven't. And unfortunately, the mortality in this group is remarkably high. We've lost a lot of participants in the last 5 years.
So Les, how do you account for self-selection for these individuals that do come back and go through 3 or 4 days of these tests, and the ones that do not come back, and how might be different, and kind of help inform your findings?
Yeah, that's one of the things we're really worried about in any cohort study is to do this. And so the two papers that I quoted had down at the bottom of the slide, that the first was the cohort design and the characteristics, and the second paper was a very detailed analysis of participants and non-participants. And to the extent that we can evaluate them in terms of their previous exposures, treatment, the previous history, because you have to remember that we have upwards of 15 years of clinical data on these folks in terms of what has happened to them. And then we took them all and we geocoded them to where they currently live and looked at the issues in terms of the census data, in terms of do we see, are we having more upper SES groups participating or not participating? And we actually found no difference in the groups overall. Undoubtedly, there's differences. There's got to be something that, some people are too busy and so on, but the participation rate in the 75% range is actually more than we had expected. But what we tried to do as much as possible is take away every barrier that we can. So the people that come back to this, everything is paid for. Their travel is paid for, housing is paid for, their food is paid for. We don't take their insurance information. So there's no chance their insurance company will be billed for anything that happens during their visit. We give them all the information back, and then we compensate them. So that we compensate them for time away from work, child care, those kinds of issues. So we tried to eliminate as much selection, but undoubtedly there is selection. And probably the only way we're going to figure this out is to look at mortality. If we start to see long-term differences in mortality between the groups that's coming back and the group that doesn't come back, but that's a pretty blunt outcome. There could be a whole lot of morbidity that is different within those groups. So I think the other way that we can approach this, and we've got some really sharp young epidemiologists that are methodologically inclined to start working on sensitivity analyses within this population to put some somewhat realistic boundaries around our estimates to say if our non-participants are this much healthier or this much sicker, how much could these estimates actually be off? So it's not satisfying, but it's kind of the best we can do.
And thank you all. Thank you for staying for a nice question and answer, and thanks to Mark for creating a world with cancer survivors for less to study. It's been an amazing, it's been an amazing lecture. Thank you.
Thank you.